Hello, good morning, everybody. Welcome to the July Journal Club. We'll get started. I hope everyone's well. It's very rainy here in Florida. Oops. Our first study is a study from Hyderabad in India, led by AIG in Hyderabad in India. It's a randomized trial looking at fully covered self-expanding metal stent versus multiple plastic stents to treat benign biliary strictures secondary to chronic pancreatitis. It's a multi-center randomized trial. Benign biliary stricture occurs in 10 to 30% of patients with chronic pancreatitis, and this is important because this can lead to cholestasis, jaundice, acute cholangitis, and secondary biliary cirrhosis, which is irreversible. And so treatment is required in symptomatic patients. Endotherapy for treatment of benign biliary stricture secondary to chronic pancreatitis involve the use of plastic stents or fully covered metal stents. Now, long-term randomized controlled trial data in endoscopic management of chronic pancreatitis-associated benign biliary strictures are needed. So the aim of the study was to look at the rate of biliary stricture resolution at 12-month post-stent removal between multiple plastic stents and fully covered metal stent. So this was a randomized trial involving multiple centers, 14 centers across 11 countries. It was a non-inferiority study, which means they're trying to decide whether metal stent is non-inferior to the more traditional plastic stent use. Now, 12-month treatment duration was allowed for both stent types, and they allowed placement of multiple plastic stents, 3 or 4, versus the placement of just one fully covered metal stent. And follow-up was then continued 12 months after the stent removal, so a total follow-up period of 24 months. So all patients over the age of 18 with symptomatic benign biliary stricture and chronic pancreatitis were included. And the definition of symptomatic in this study was cholangitis, jaundice for more than a month, and elevation in alkaline phosphatase levels. So these are the baseline characteristics. 84 patients were randomized to plastic stents, 80 patients were randomized to metal stent. And the median baseline bilirubin level was 1.4 in the plastic group, 1 in the metal group, and the alkaline phosphatase level at baseline was 262 versus 337. Now, this is the procedure outcome. Now, when they looked at the primary outcome measure of stricture resolution, they found that the rate of resolution of stricture with plastic stents was 77% versus 75% for metal stents. The p-value was significant. Basically, with this non-inferiority study, it means that metal stent is non-inferior to plastic stents. When they looked at the overall related serious adverse events, there was no difference between the two groups at 19 versus 23.8%. However, the main benefit of metal stent versus plastic stent in the study was that the mean number of ERCPs was significantly lower for metal, and also the mean number of stents placed was also lower with metal versus plastic stent. When looking at the adverse events, the serious adverse events included abdominal pain, cholangitis, post-ERCP pancreatitis, perforation, post-sphincterotomy bleed, and then importantly, stent migration. And as you can see, there was no difference between the two groups in any of these adverse events. The main limitation of this randomized trial is the generalizability. Now, these procedures were performed in tertiary referral centers by highly skilled endoscopists, which do limit the generalizability of this study, especially because this population in particular can be very challenging in terms of their ERCPs. And also the follow-up was stopped at 24 months, which is pretty long, but strictures can recur after 12 months following stent removal. So the take-home point from this study is that single, fully covered metal stent and multiple plastic stents are comparable in terms of their treatment efficacy and safety in patients undergoing endotherapy for chronic pancreatitis-associated benign biliary strictures. Our second study is by Maria et al. It was published in Gut. It's looking at the use of artificial intelligence for the development of an EUS convolutional neural network model trained to augment the diagnosis of autoimmune pancreatitis. Now, this study is important because trying to distinguish autoimmune pancreatitis from pancreatic cancer in particular can be very difficult. It is known that 2 to 5% of patients who have undergone pancreatic surgery for suspected pancreatic cancer actually have autoimmune pancreatitis in their surgical pathology. And EUS-guided tissue acquisition for the diagnosis of autoimmune pancreatitis can also be very challenging, with reported diagnostic accuracy rate of only up to 58%. So these authors try to use artificial intelligence to allow a more accurate diagnosis of autoimmune pancreatitis and allow an accurate distinction between autoimmune pancreatitis and pancreatic cancer, as well as other benign diseases such as chronic pancreatitis. So this study was conducted at the Mayo Clinic in Rochester. They took 583 patients who had various disorders. They had 146 had autoimmune pancreatitis, 292 pancreatic cancer, 72 patients had chronic pancreatitis, and 73 patients had normal pancreas. And they extracted over 1 million images from these 583 patients. Then they set to work in phases. So first is the training phase, where you're training the convolutional, setting up the convolutional neural network to form your model, then validation to see how accurate this model is, and then you test it on subsets. And so what they wanted to look at was the operating characteristics of the convolutional neural network model for distinguishing autoimmune pancreatitis from pancreatic cancer, chronic pancreatitis, and normal pancreas. Then they compared this AI model to 7 expert endosonographers. So the results were quite impressive. So this row here looks at the operating characteristics of the EUS-based convolutional neural network model. The first column is the sensitivity. And as you can see, when using the model, the sensitivity for distinguishing autoimmune pancreatitis versus all other diseases, so distinguishing it from pancreatic cancer, chronic pancreatitis, or normal pancreas. As you can see, it ranges from 0.9, was it 90% basically, to 95%. They divided out the operating characteristics into stills versus watch videos, but as you can see, it's still very impressive all across the board. The specificity was slightly lower. As you can see, it ranges from 59% to 90% for stills, and it ranges from 71% to 98% for videos. Now, this is the receiver operating characteristic curve. All this means is that this line here is a line, you're looking at the area under the curve. So anything above this line here, which goes across, which denotes an area under the curve of the receiver operating characteristic of 0.5, anything above this is considered okay. Now, if the area under the curve is above 0.9, is considered to be an excellent test or an excellent model. So as you can see, when comparing, when looking at the ability of this convolutional neural network to distinguish autoimmune pancreatitis from all benign diseases, the area under the curve is 0.92 for stills and 0.94 for videos. When looking at the ability to distinguish autoimmune pancreatitis from pancreatic cancer, again, very high area under the curve of 0.95 and 0.96. When trying to compare autoimmune pancreatitis with chronic pancreatitis, lower in terms of the area, but still considered excellent if it's above 0.8. And as you can see, the area under the curve is 0.87 and 0.89. again, for distinguishing autoimmune pancreatitis from normal pancreas, still performs very highly, 0.98 and 0.99. So what they then did was compare the artificial intelligence model with 7 expert endosonographers. And the results, again, are very impressive. When looking at the sensitivity, the AI outperformed expert human endosonographers with sensitivity of 0.88 versus 0.54 when detecting autoimmune pancreatitis from all other conditions. When trying to distinguish autoimmune pancreatitis from pancreatic cancer alone, again, the sensitivity was 0.88 for AI, 0.54 for human endosonographers. The limitation of this study is that the images and videos obtained to build your convolutional neural network model is for a single center only. And the cases used in the study were obtained retrospectively, and therefore further studies are needed on prospectively obtained images. So the main take-home point for this study is that using artificial intelligence to develop EUS-based convolutional neural network model was able to accurately differentiate autoimmune pancreatitis from pancreatic cancer and chronic pancreatitis. And this model enabled more accurate and timely diagnosis of autoimmune pancreatitis and pancreatic cancer, and hence has the potential to improve patient care. Our next study looks at the rate of venous thromboembolic disease in inflammatory bowel disease. This was published by Bernstein et al. In the American Journal of Gastroenterology this month. The risk of venous thromboembolic disease, so DVT and PEs, has been known to be increased in patients with inflammatory bowel disease. And we've known this for the last 20 years, but there is currently lack of information on the effect of the incidence of venous thromboembolic disease on recent developments in the management of IBD, on the incidence of VTE disease, and also we presume, because we have have this knowledge of this increased risk of thromboembolic disease, that we are managing it better in IBD patients, but nobody really knows. So the aim of the study was to look at the incidence of venous thromboembolic disease in patients with IBD over time to see if really our new developments in medical management of IBD and also our enhanced knowledge and more generalized knowledge of this increased risk in our IBD patients has made any difference in the incidence of thromboembolic disease in these patients. So it was a population-based study using the IBD epidemiology database at the University of Manitoba. They looked at patients with IBD from 1985 to 2018, and they basically looked at 11,000 Manitobans with IBD. And then they matched these IBD patients with over 100,000 controls without IBD. And basically the patients were matched for age, gender, and postal area of residence. Now, this is not surprising, although a little disappointing, probably. As you can see, the incidence, so cases mean IBD patients, control means normal patients, regular people without IBD. And as you can see, the incidence of thromboembolic disease was 7.6%. In the 7.6 in the IBD group, and 3.26% in the non-IBD patients, and this difference was significant. If you look at patients with Crohn's versus ulcerative colitis, as you can see, the incidence of thromboembolic disease was higher in Crohn's versus patients with ulcerative colitis at 8 versus 6.9%. Then they looked at the incident rate of thromboembolic disease per 100,000 patients in IBD versus non-IBD individuals. And as you can see here, again, cases mean IBD, controls mean no IBD. And as you can see, if you have inflammatory bowel disease, you are overall 2.36 times more likely to develop thromboembolic disease compared to a population without IBD. And this increased risk was seen across all the age groups. When dividing between Crohn's disease and ulcerative colitis, the same was seen. If you had Crohn's disease, you were 2.65 times more likely to have thromboembolic disease versus non-IBD people. And again, same for ulcerative colitis patients. The authors then plotted the age standardized incidence rate of thromboembolic disease for IBD and controls over time. And as you can see, the annual percentage change in the incidence of VTE in IBD group was only minus 0.7, which means that every year there's only a 0.7% decrease in the incidence of thromboembolic disease each year. They then also looked at so they performed a multivariate logistic regression to examine factors associated with thromboembolic disease in IBD patients. And these were the factors which lit up. So as you can see, if you've used anti-TNF agents less than 3 years, if you use steroids plus anti-TNF alpha agents, if you've been hospitalized, if you have a history of cancer, then you are more likely to develop thromboembolic disease. The main limitation of the study is that it's a population-based study using database, and there is a risk of error, as with all these database studies, in the diagnosis of thromboembolic disease. Also, the data on the use of thromboembolic prophylaxis in patients who were admitted to the hospital were not available. So an interesting question would have been whether these IBD patients are developing DVTs and PEs during the hospital stay in spite of DVT prophylaxis. However, that information is not available. So the main take-home points is that inflammatory bowel disease is a significant risk factor for developing venous thromboembolic disease. However, despite the advancement in IBD management in the last 30 years, the rates of thromboembolic disease in IBD patients have remained fairly consistent. So we need to review current practices to ensure that thromboembolic disease prophylaxis is being administered in hospitalized IBD patients, and also to identify outpatients with IBD who are at high risk for developing venous thromboembolic disease to determine the need for outpatient thromboprophylaxis. Our next study is a randomized trial of a transglutaminase 2 inhibitor for celiac disease. This was published by Chupan et al. In the New England Journal of Medicine this month. Celiac disease has a prevalence of 0.2 to 2%. It's an autoimmune condition, and it's triggered by ingestion of gluten in grains such as wheat, barley, rye, and oats in patients who are genetically predisposed. So these are patients with genotypes HLA-DQ2 and HLA-DQ8. The diagnosis is made by testing for elevated serum transglutaminase 2 IgA antibody, and also on biopsies of small bowel intestine, which shows villus atrophy, crypt hyperplasia, and intraepithelial lymphocyte infiltration. The standard treatment is gluten-free diet. However, there is a need for more effective medical treatment in conjunction with gluten-free diet, because even in patients who do adhere to a strict gluten-free diet, the reversal in histological changes seen with celiac disease often is not fully reversed. So the aim of this randomized trial was a clinical trial of a novel transglutaminase 2 inhibitor in celiac disease. So this was a phase 2 randomized trial conducted in 20 sites in 7 countries in Europe. They included adult patients up to the age of 65 with biopsy-confirmed celiac disease who had a negative anti-TTG IgA at baseline. They also obtained baseline small bowel biopsies and included patients with mean ratio of villus height to crypt depth of greater than 1.5. The patients were randomized into 4 groups, placebo, and then 3 different doses of this novel anti-TTG anti-TTG agent called Z1227. The patients were treated for 6 weeks, and then each patient received a daily gluten challenge of 3 grams of gluten. Then 6 weeks post treatment initiation, patients underwent repeat EGD for repeat small intestinal biopsies. So 41 patients were enrolled at the lowest dose of Z1227, 10 milligrams, 41 patients to 50 milligrams of Z1227, 39 patients to 100 milligrams of Z1227, and then 38 patients to placebo. The first outcome they looked at was the ratio of villus height to crypt depth. And as you can see, when compared to placebo, the estimated difference in ratio for these different doses of Z1227 was 0.4 for 10 milligrams, 0.49 for 50, and 0.48 for 100 milligrams. And as you can see, each dose of this Z1227 resulted in a significant lower attenuation of crypt height to crypt depth. And basically, it shows that there is an attenuation of gluten-induced duodenal mucosal injury with all 3 doses of Z1227. When looking at intraepithelial lymphocyte density, compared to the placebo, all 3 doses of Z1227 resulted in lower intraepithelial lymphocyte density compared to the placebo. When looking at the symptom index, lower celiac symptom score was seen compared to the placebo. For all the doses, however, only the dose that was highest, 100 milligrams, resulted in a significant lowering of the symptoms. These were the adverse events. The adverse event rates are quite high across the board, including with the placebo, which was 79%. And the adverse event rate for all the Z1227 doses was 80%, 73%, and then 80%. The doses included, this adverse events included headaches, nausea, diarrhea, vomiting, and abdominal pain. The main limitation of the study is the small sample size. They did experience some loss of patients to follow-up, and also there is a short duration of treatment follow-up. However, the main take-home point is that in this preliminary trial, treatment with selective oral transglutaminase 2 inhibitor, Z1227, attenuated gluten-induced duodenal mucosal damage in patients with celiac disease. Larger studies are obviously needed to further assess the safety and efficacy of this drug. Our last study is a study published in the Annals of Surgery. This was a study on the management of neoperitoneum. And I chose this study because I thought it was interesting, because obviously we all perform procedures, it's something that we do encounter on a, during our work career, and this, I think it has quite interesting results. So pneumoperitoneum can come from multiple etiologies, obviously following an intervention. Other non-interventional or non-traumatic causes include bowel obstruction, patients with spontaneous perforation in IBD, diverticular disease, bowel ischemia, cancer, radiation therapy, and chemotherapy agents such as bevacizumab. Go to most aggressive treatment in patients with pneumoperitoneum and suspected bowel perforation or viscous perforation is emergency laparotomy, but it is associated with a significant mortality rate of 40 to 55%. So trying to balance the risk of a patient having a possible risk of a patient having pneumoperitoneum from a possible visceral injury versus the risk of surgery can be challenging. So the aim of this study was to determine the outcomes of 3 different approaches to pneumoperitoneum, which included, number 1, comfort measure, number 2, non-operative, which was every treatment except actual surgery, and then surgery. So these authors conducted this retrospective study using electronic health records at Partners Healthcare, which serves about 1/3 of all hospitalized patients in the Boston area. So they looked at patients with free air reported on CT scans who also had an ICD-9 diagnosis code for unspecified peritoneal disorder or visceral perforation. Then when they found these patients, they went through each chart manually to collect the necessary data. As mentioned previously, the 3 main treatment approaches were defined as comfort measures, which were symptom alleviation only. Second was non-operative, which included antibiotics, IV fluids, use of vasopressors, percutaneous drain placements. And then third was operative, which was performing surgery within 24 hours of surgery consult. So they found that comfort measures were 40 patients. In the non-operative group, 202 patients and 199 patients were in the operative group. This is an interesting finding from the CT, is that they found extravasation of contrast was seen in 50% of the comfort measure, 26% of non-operative group, and 26% of the operative group. And the various predicted sources of pneumoperitoneum included stomach, small bowel, colon/rectum, and also kind of unknown, unclear. Now, the authors looked at both short-term and long-term survival. Short-term included up to 90 days, and then 2 years survival was the long-term data. Now, as you can see, if you are looking at just comfort measures, the survival rate is very, very low. It's in the region of less than, it's very, very low. It's basically 1 out of 40 patients survived, at 30 days. Sorry, this is a 30-day data only for the comfort measure because they just didn't survive very long. Now, for non-operative treatment group, the data are available for 2 years. And as you can see, there was no difference in 2 years survival between the non-operative and operative groups. The p-value was 0.53. Next, Dr. Kumar, will you stop moving the mouse for me? For some reason, you're drawing a load of all over the slide. Thank you. Thank you. Next is looking at the non-operative versus operative patients in the setting of peritonitis. And for this, the p-value is significantly different between operative and non-operative, with survival being significantly higher for the operative group with p-value of 0.02. Next, when looking at patients with pneumoperitoneum but no peritonitis, the non-operative, there was no difference between the non-operative and operative groups. goodness gracious. Okay, I don't know how to make these scribbles go away. I apologize if the slide's not very clear. So in terms of, again, short-term survival, there was no difference between non-operative and operative groups for 30-day mortality. The median length of hospitalization was, however, significantly higher for the operative group. Also, patients in the operative group were more likely to have wound vacuum assist device on discharge, dependent on TPN at discharge, were more likely to have stoma and more likely to be discharged to a long-term care facility. For logistic regression performed for short-term outcomes, the operative treatment group, as you can see, in the operative treatment group, the length of stay of more than 5 days in the hospital was significantly higher. Also, patients undergoing surgery were less likely to have percutaneous drainage, were more likely to have TPN at discharge, and less likely to be discharged home. When looking at patients who had surgery and they had peritonitis, the 30-day mortality was significantly lower. Again, we're looking at the factors associated with 2-year mortality. The main things associated are a type of operative treatment. As you can see, the type of operative treatment that you received did not significantly impact 2-year mortality. So the main limitation of this study is that this is the retro. Just 1 second, let me try this. Okay, that's better. So the main limitation of this study is that this is a retrospective study. The potential for error occurs in the fact that ICD-9 codes were used to identify patients, and therefore there is a potential for missing patients that were miscoded. Also, the presence of peritonitis were noted in medical records, may have been misdiagnosed and may be confused with patients with abdominal tenderness rather than actual frank signs of peritonitis. So the main take-home point is that in patients with pneumoperitoneum, non-operative management in the absence of peritonitis was associated with decreased morbidity and equivalent mortality. Operative intervention was associated with reduced mortality in patients with peritonitis. Therefore, non-operative treatment with diligent monitoring may be safe and effective in patients with pneumoperitoneum without peritonitis. So a quick recap, single fully covered metal stent and multiple plastic stents had similar efficacy and safety in patients undergoing endotherapy for chronic pancreatitis associated benign biliary strictures. Using artificial intelligence to develop EUS-based convolutional neural network model was able to accurately differentiate autoimmune pancreatitis from pancreatic cancer and chronic pancreatitis. And this model enables more accurate and timely diagnosis of autoimmune pancreatitis and pancreatic cancer, and hence improvement in patient care. IBD is a significant risk factor for developing thromboembolic disease. And despite advancement in IBD management in the last 20 to 30 years, the rates of thromboembolic disease and IBD have remained fairly consistent. And current practices need to be reviewed to ensure DVT prophylaxis is being administered in patients with IBD and to identify patients with IBD who are at higher risk for thromboembolic disease to determine the need for outpatient thromboprophylaxis. In this preliminary trial, treatment of selective oral transglutamase 2 inhibitor attenuated gluten-induced duodenal mucosal damage in patients with celiac disease, but larger studies are needed. And then finally, in patients with pneumoperitoneum, non-operative management in the absence of peritonitis was associated with decreased morbidity and equivalent mortality. Operative intervention was associated with reduced mortality, but only in patients with peritonitis. Therefore, non-operative treatment with diligent monitoring may be safe and effective in patients with pneumoperitoneum, but without peritonitis. So our next journal club is August 4th, the first Wednesday of August. Again, thank you so much for joining us this morning. I'm grateful and hope you found this to be to be helpful and useful. Thank you so much.